50% adherence is enough, is it, with modern HIVs? Well, we'll see. Where's my button here? These are my disclosures. I've been working on adherence for a long time and working with the Arctics group. I just want to point that out because I have had a lot of information and a lot of interest in adherence over a long period of time. This is what I'm going to talk about. I'm going to talk a little bit about, and I was happy to see in that introduction that David did that so many people are here for the first time, because most of the rest of you will think, here he goes again with the same old stuff on adherence. And I'm going to talk about some taxonomy because I think it's very important. I'm going to discuss factors that impact dosing regimens. I'm going to define a term called forgiveness in quantitative terms and show some data that Kelly has, I think, generated. I'm going to talk about an analysis of dosing regimens for HIV drugs with short half-lives, and I'm going to talk about dolutegravir in some detail and give some examples of dose and dosing regimens on both the QD and the BID regimens, and finish up with talking about the importance of patterns, not percentages of adherence, and then use some data from TB and some final conclusions. Well, is 50% adherence enough with modern HIVs? I think there's a tendency to think that that may be true and that there's a wide therapeutic index. But in fact, 50% is not enough, and I'm going to show you some details on that in just a moment. I do support the development of and value of long-acting drugs and formulations. I think we do need drugs that we don't have to give every day or even twice a day. But I'm going to focus on the topic of forgiveness because I think that's what really determines the dosing interval of a drug and how often we do have to give it. So here's the taxonomy part. Adherence is really a time-dependent phenomenon, and we can't discuss it with just a single metric. We have initiation of the dosing, and that can be problematic for certain kinds of drugs, and now these days based even on things like cost. And 25% of patients don't actually fill or take their prescription, so that's a fairly large percentage. I'm going to be speaking mostly about implementation. And implementation really represents what's happening when the patient is on the drug. And what I'm going to show you in some data I'm presenting is that on a daily basis, 15% of patients do not take the drug as prescribed. And then finally, I'm going to talk just briefly about persistence. And persistence really is the amount of time that the patient stays on the drug. And this is a very important, which I'm not going to talk very much about today, and that is that 40% of patients in HIV have discontinued their drugs by the end of a year. So I want to talk really about the factors that are important in designing a dosing regimen. Most importantly, we talked a little bit about this, but we need to talk more about it, is drug potency. And that's really something that Courtney was reflecting on, and that is if we have a drug with a very high IQ, we're thinking of that as a very potent drug because of wide therapeutic index. And so having a potent drug is actually quite important. I'm going to talk a lot about drug half-life, and I think everybody in the room knows what I mean by a drug half-life, but the half-life of the drug is really very important in terms of determining the dosing interval. And then finally, talk about the therapeutic index, and that's really the relative safety of a drug versus its efficacy. And that's another important thing that gets integrated into talking about a dosing regimen. So let's first talk about what forgiveness is. And probably most people in this room have a general idea of what it is, but let me talk about it in a more specific way in terms of a definition. And I'll use it letter capital F to define forgiveness, and it's really how long the drug action continues at therapeutically effective concentrations after a last taken dose. And you can express that in several different ways, including the post-dose duration of effective action minus its recommended dosing interval. And mathematically, forgiveness is the difference between the drug's post-dose duration of action and the prescribed dosing interval. And so you can express it in a couple of ways. One is just by subtracting the dosing interval from the duration of action, or a ratio of the dosing interval to the duration of action. But forgiveness is really very dependent on the drug dose and the drug half-life, not just on the half-life, but on the drug dose as well. Now, one approach to extend forgiveness is dose escalation, but that approach is often limited by dose-dependent toxicity. And what I want to highlight here in red, because I think it's so important, and again, I'm not going to talk about it, is that the impact of early discontinuation, which is the biggest problem in HIV, is not offset by a few days of forgiveness. This is the only slide I'm going to really show about persistence, but what it shows is that 40% of patients with HIV will have discontinued treatment by month 12. For some diseases, it's even higher, like depression. For other diseases like osteoporosis, it's lower. But HIV is actually quite high when you think about the 40% of patients that have stopped their treatment by the end of a year. And for drugs with relatively short half-lives, what we really have to ask the question is, once daily dosing better than twice daily dosing? And I'm going to go into some detail on that in just a moment. So I'm going to look at an example of a dosing regimen for a patient treated with dolutegravir. And I'm just going to talk about dolutegravir. I'm not going to talk about it in terms of the other drug combinations that would be used with dolutegravir. And here are some of the data that comes from actually the prescribing insert for dolutegravir. And what I want to highlight here is that in the adult population, treatment-naive patients, the recommended dose is 50 milligrams once daily. And we heard already that that's actually probably the most common regimen that's used in patients that are started on dolutegravir. But let's look a little bit more about the details of dolutegravir pharmacokinetics. And what you see is that, again, there's really a relatively narrow index in terms of the area under the curve, which is a measure of drug exposure between the 50 milligrams once daily and the 50 milligrams taken twice daily. Again, it's not proportional. There's actually a somewhat decreased area under the curve with the 50 milligrams twice daily compared to the 50 milligram once daily. Importantly here is that dolutegravir has a terminal half-life of approximately 14 hours and an apparent clearance of 1 liter per hour, which is based on population pharmacokinetic analyses. And this is just a picture of the mean plasma concentrations of dolutegravir plotted on a semi-logarithmic scale. And you can see in the gray area here that the first 24 hours, the dolutegravir concentration, excuse me, reflects its half-life. And that by the end of 24 hours, we're beginning to get near what might be the minimum effective concentration for the drug. So I want to show you some examples of dose and dosing intervals on a QD and a BID regimen, which is, I think, actually quite interesting and probably something that's not intuitive when you see the data. So first I want to show you what happens when you give a dose of the drug. This is just a graphical demonstration of what happens when you take a drug when you have perfect adherence. You see the concentrations go up to a peak, down to a trough, up and down, and quite soon one gets to a steady state concentration. Now here's some real data, and the dots at the bottom represent the time of the dosing, that's when the dose is taken. Now here's a real dosing regimen from an actual patient. And you see the blue lines here represent the actual concentrations. Now these are blood concentrations, Courtney, not tissue concentrations. But you can see there's quite a variation in the plasma concentrations of the drug. And the vertical yellow lines here represent missed doses. And I'm going to come back to that a little bit later on. But you can see that there's a very erratic pattern, for example, here of missing doses. And in some cases, it might represent patients trying to make up for missed doses by taking an extra dose or two. And in that case, the concentrations may raise to a point where you're getting some toxicity. And in other cases, that periodic loss of periodic missing of the drug leads to a periodic loss of effectiveness and the potential for the emergence of drug resistance in HIV. Now, everybody knows, and it's true, that if you give a drug on a daily basis, that patients on a daily time frame are more likely to take the drug than a patient who's on a BID regimen. And that's really what's just shown on this particular graph. You can see that on a daily regimen, patients take about 94% of the drugs over a period of time of close to a year. And a twice daily regimen, a BID regimen, that number is only 84%. That is 84% of the total number of doses that were prescribed or taken by a patient on a BID regimen compared to the OD regimen. Now, what's really interesting is what that means in terms of considerations of BID versus QID dosing in terms of plasma concentrations. And what this little graph is trying to show you is that the red line represents the QID or QD dosing regimen, and the blue line represents a BID regimen. Now, if you miss one dose on a QD regimen, you can see that the second day, the following day, you've fallen below some potential minimum effective concentration. But with a BID regimen, it actually takes three missed doses to fall below that regimen. It's interesting, but the important part is that because of the way dosing regimens work and the way that people take their drugs, if I show you in this slide, on a QD dosing regimen, 73% of the patients will actually have a cumulative dosing intervals that are greater than 36 hours by missing just a single dose. And on the BID dosing regimen, only 54% of the patients actually have dosing intervals of greater than 36 hours where they might fall below some minimum effective concentration. So that's actually quite interesting in that the BID regimen actually has fewer times or fewer durations where the patient has actually fallen into a concentration that may be below the minimum effective concentration. Now I want to come and proceed to talk a little bit about patterns of poor adherence, because we tend to express adherence as a percentage, and it's not a percentage. It's actually much more complicated than that, because non-persistence in many chronic diseases is really the cause of therapeutic failure, and this is relatively easy to detect using pharmacy refill data. But using percent adherence as a measure obtained from pharmacy refill data is not helpful in deciding how to intervene and improve adherence. And we need more granular data for appropriate counseling of the patients that we're caring for. So patterns of poor adherence are much more difficult to detect, may go on for long periods of time, and frequently lead to polypharmacy and the potential for drug toxicity because patients then demonstrate failure. We don't understand the reason for that failure being poor adherence or even missed doses, and so additional drugs are added or drugs are changed to those individuals' regimen. So just as an example of implementation examples, and in these particular 4 patients that were followed using electronic monitors, you see that each of these patients took 90% of a prescribed number of doses during a 12-month period. But you can see that that's quite different. Initially in panel A, you have a patient there who initially decided or was trying to decide whether or not to take the drug and missed the first week or 2, and then was actually a very good adherer. In panel B, we have a patient who's discontinued the drug before the end of the prescribed dosing interval, and you begin to actually get some useful information by seeing this kind of plot, because you begin to see that as a patient decides whether or not he or she is going to continue to take the regimen, they begin getting more erratic in terms of the timing of the dose and the number of doses that they miss. In panel C, we see a good example of what we call a drug holiday, a patient who stops the drug for a significant period of time. And if this were an HIV patient, this patient might well fail even when they go back on the drug. And then in panel D, we see a patient who's pretty good along the way in terms of times of doses and misses doses relatively infrequently, but again, misses about 10% of the doses. So these are just examples of different implementation examples, and understanding that the details is actually quite important. And just some more implementation examples. Again, these are patients on a BID regimen, as you can see by the top and the bottom, the way this is laid out. The time of the dosing is indicated by the dots, and the missed doses are indicating in this slide by the vertical gray lines. And not surprisingly, you see that patients who are taking a BID dosing tend to miss their dose more in the afternoon than in the morning. You can see that on the top 2 panels. But again, you see that many different patterns of adherence, even on a BID dosing, from patients who miss occasional doses to those that miss in pockets of dosing and have multiple missing doses. So again, that indication or that use of 75% of prescribed doses to try to understand what's happening with an individual patient in terms of his or her response to therapy is really not the best way to do it. We have to have the detailed dosing information, and in order to intervene with patients, we need to have that information in a timely fashion, and there are a number of ways now of going about doing that and getting that information on individual patients. So let me just illustrate a couple of clinical studies. And here's one from my colleague Charlie Flexner that did a study not all that long ago, but a little while ago, looking at once daily versus twice daily combination ARV therapy in the treatment-naive patients in an ACTG trial. And basically, the conclusion was that the subjects on the QD regimens had better adherence, as I showed you early on the earlier slide, and the treatment outcomes overall were similar in the BID and the QD arms, but the subjects with RNA levels greater than 100 copies per ml had better systemic viral resistance or viral response compared to the BID regimens at 48 weeks. So it suggests a possible advantage, and I'm taking these words right out of Charlie's paper. So the question really is, BID better than QD? Well, again, it's really going to be dependent on things like the dosing interval and the half-life of the drug. I'm just showing you another study here back in the old days of protease inhibitor. It showed that protease inhibitors, again, this is John Urquhart's work from many years ago, have not been very forgiving drugs. And I think we knew that actually a long time ago, that the protease inhibitors, in fact, were very dependent on very, very good adherence. Now, I want to show this one TB data just because I think it's very important, and it's a recent data generated in a series of actual clinical trials that were ongoing in patients with drug-sensitive tuberculosis. And in these trials, what was actually demonstrated, and it's perhaps not as easy to see in this slide, is that if you look just at the red line, patients with less than 90% adherence, and these were not detailed dosing regimens in these patients, but so this is an overall percentage of adherence, actually had a substantially higher increase in relapse, actually about 20%. So these are relatively modest differences in total adherence, and it turns out that what I think is also learned by this study is that in particular, rifampin is not a very forgiving drug, and missing doses of rifampin may lead to both failure but also to multi-drug resistant tuberculosis. So my conclusions are that contrary to popular belief for drugs with half-lives of less than 24 hours at the same total daily dose, BID dosing may provide better coverage than QD dosing. And I think we could ask the question of whether or not patients are willing to take BID dosing. I think we know that in a lot of diseases, BID dosing is not problematic, and patients are, if they're trained to how to take a BID dosing, will in fact not have a great deal of difficulty with it. And I want to also emphasize that dosing patterns matter, that for drugs with narrow therapeutic windows and the potential for generating resistance, consider dosing histories and provide adherence intervention. And this applies in HIV, TB, as well as many other infectious diseases. And we do need more potent drugs for many diseases with longer half-lives and a wide therapeutic index. So I'm going to stop there and leave time for questions.